Welcome, everybody. I mean, I'm listening to all of the greetings, and clearly there are a bunch of people here who know each other and have community, which I think will be really a wonderful thing for this discussion. My name is Richard Jeffrey Newman. I am the host and curator of a literary reading series in Jackson Heights, where Zenaria and I live, called First Tuesdays. And I am going to be the host and moderator this evening. And I wanted to take just 2 minutes to kind of tell you how that came to be. Zenaria reached out to me, I think it was by email, asking for help with a grant proposal that she was writing. She was writing a proposal for the Queen's Council on the Arts and Individual Artists Grant. And I actually don't remember how she got my name, but anyway, she reached out to me and we met and sat at Espresso 77 and ended up having a very, very long conversation, a really, really wonderful and interesting conversation about the book that she is writing, which has to do with her experience as a doctor and as a doctor in training, and how that impacted her life and her ideas about medicine and all of that. And in the course of that conversation, I realized I had just finished reading Elizabeth Wood's memoir, called Bound. I'll say a little more when I introduce them, but I had just finished reading Elizabeth Wood's memoir, which is about her experience during her mother's illness and death from cancer, from the other side of the medical establishment, right? From as a patient, well, as an advocate, really, a patient advocate, being an advocate for her mother and watching her mother's experience going through and dealing with the medical establishment in that way. And so I said, hey, you two ought to talk to each other. They did. Zenaria, as part of the grant, is required to do some sort of public event. Hence, we are all here this evening. And they have come up really with what I think you'll find is a really, really interesting set of readings. And hopefully what will follow will be a really kind of interesting discussion. So the way it'll work is I'm going to introduce Zenaria and Elizabeth. Nicole Haratunian is she's going to be managing the chat. So if you have questions or comments, feel free to just put them in the chat and she will kind of read them out. We're going to hold any questions until both readings are finished. And then after that, I'm going to say just a couple of words about the readings, and then we'll open it up. We'll open it up for conversation. So if I think that sounds okay to everybody, let me introduce. You know what I realized? We did not decide, or you didn't tell me who's reading first.
I believe Zenaria is.
Okay, so Zenaria is reading first. I'm going to introduce them both now, and then Zenaria will read, and then Elizabeth will read. I'll be able to sort of sit back and listen. So Zenaria Williams is an ophthalmic plastic surgeon in Queens. She is an author currently finalizing a novel that focuses on themes illustrating the consequences medical training has on doctors. And Elizabeth Wood is a PhD living in Queens. She's a sociologist and the author of the memoir Bound, A Daughter, a Dom, and an End-of-Life Story. And you can actually see a copy in the background of Zenaria's screen right there. Describing her experience with a dying mother and the unintentional inhumanity of the healthcare system. I'm going to get perspectives from opposite sides, maybe not opposite sides, but from different sides of this experience. And with that, I give you Zenaria Williams.
Thank you. Thank you, Richard, Nicole, and Elizabeth for deciding to do this with me before you knew that you actually had to do it. I won this grant, and it was originally planned to be a reading at Espresso 77, which is in Queens, but the pandemic and everything, that wasn't going to happen. And so I'm actually happy that I can have this in the Zoom setting because more of my friends can join who are outside of New York City, and we can have kind of a more national community in addition to a local one. So I'm just going to remind my husband that I am presenting Okay. So I'm going to start with the opening chapter. This opening chapter, actually, first I'll go back. I have the published work of Nicole, Richard Jeffrey Newman, and Elizabeth here behind me. And on this side are the draft of my manuscript, these two bound, which I'm on probably the 18th revision. So you are hearing a draft version, but semi-polished, which is an ongoing process, but this is part of my draft. The opening chapter is designed to put the reader in the heart of Dr. Eva Scott's story. And then the book takes a step back to illustrate how she got here. It's not common to hear the doctor-patient relationship described in the way that you're going to hear, but it is the experience of many who are in medical training. Chapter 1, Battlefield. Patients are the enemy. That's what I used to say. I didn't start out thinking like that, but after a few months of internship, I realized it was true. One night on call, 21 hours in, 15 still to go, my screamer paged out in triplicate bursts, causing heart palpitations and a chill of panic every time. Beep, 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 beep. More enemies were coming. I needed to go up 2 flights of stairs to see a patient, a quick dash in any other circumstance, but I took the elevator. No stairs at night in this state hospital. I didn't want to risk facing an escaped incarcerated patient from the prison ward, hiding in the shadows. My fears were perhaps overcautious, but not completely unrealistic. I had heard stories. Perspiration coursed down my patient's forehead when I got into the room that smelled like sour gym clothes. He rocked himself on the bed, shivering. Long arms wrapped around long legs, tucked underneath a tattered woolen sweater. Blood speckled the tissue as he coughed and spat. The same crumpled tissue swiped drippings from his runny nose. Glassy eyes looked up and around the room without seeing, and crusted scars marked up his hands and wrists where veins should have been. A drug addict. I did not introduce myself with a smile like I used to. My first thought was not, how can I help heal this man? Or how can I calm his fears? I used to think that way. But 6 months into my residency, my first thought was, shit, this guy's going to infect us all with tuberculosis. My second thought was, why can't these people go into withdrawal during the daytime? In medical school, I encountered many doctors who seemed to have a complete lack of sensitivity toward patients. Their attitudes made me cringe. I remember one in particular who always cut his patients off, insisting on brief answers to his rapid fire questions before exiting the room. At the time, I felt doctors like him dishonored the profession and didn't appreciate the privilege they had to practice medicine. But after only a few months of residency training, I was one of them. While rummaging through the cabinets to get a mask for this coughing patient, the screaming grenade blasted me again. Beep, 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 beep. The nearest phone was at the nurse's station, nested near a pile of carbon copy radiology requests, the yellow and pink pages. This was an era before electronic medical records, before the computer screen became the primary interface for patient care. This is Dr. Scott. I was paged, I said, grumbling into the heavy receiver, sleepless at 4 a.m. Yes, doctor, we have a patient who just had explosive bloody diarrhea. You have to come see him. After working 21 hours with 15 still to go, your mind gets cloudy. It's hard to think. You feel sick to your stomach. You forget things, the correct medication dosage, an allergy, a critical symptom to ask about. And when you forget things or make mistakes, someone usually suffers. It might be the patient, but you'll almost certainly be berated by your senior resident or attending in front of your peers the next day after you've already cursed yourself for making the error and not being strong enough to keep it together. After working that long, you stop caring about things. a patient's pain, review of a critical x-ray before going home, and even yourself. After months of working like this, it's a struggle to remember what matters to you anymore because you've given up everything else in your life for the sake of an oppressive job that doesn't care about you. Okay, I'll be up, I said in a huff. As soon as I hung up the phone, my pager screamed again. Beep, 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 beep. My pulse raced at the sound. I felt a furious and angry burn in my stomach. I already admitted 4 patients to my service. Coughing up blood guy was going to be number 5, bloody diarrhea guy would be number 6, and this page from the psych ward was probably number 7. The enemy was gaining ground. This is Dr. Scott. I was paged, I said. Sorry to disturb you, doctor, but I'm calling about Nicole. She swallowed a handful of batteries again, and she needs to be transferred to your service. What is she even doing up at this hour? I asked, almost yelling, then feeling remorse for my sharpness, but not apologizing for it. Beep, 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 beep. It's the ICU, I said, tempering my voice. I have to go. I'll be up there when I can. I placed the receiver down and raised it again. This is Dr. Scott. I was paged. The inmate you just admitted for alcohol withdrawal is getting more confused and combative. He just yanked his IV, said the ICU nurse, the one who resented calling interns doctor. Increase his Ativan and I'll be down as soon as I can. You need to come now, she said, hanging up. I checked my watch. The next day was beginning, even though the previous one never ended. Without the grace of a 20-minute power nap or mandatory breaks like the nurses got, I was going to meet the new workday deprived of sleep and be expected to keep up in all the usual ways. Every patient update would need to be committed to memory by 7 a.m. rounds. Every unanswerable question fired at me by the senior resident or attending would need a respectable response. Every abnormal test finding would need to be investigated and verified so that nothing fell through the cracks. And I would need to make sure my peers saw that even after being awake for 21 hours with 15 to go, I was still just as tough as they were. Several cups of coffee and Sudafed would keep me coherent and alert until about 2 p.m. Then I'd start to crash and become aware that I was in no condition to perform a procedure, to prescribe medication, to drive home. But I ended up doing all those things without memory of it. Somehow it turned out all right. There were no casualties, not that day. It's embarrassing to admit all this, shameful even. What doctor will admit to hating her patients? What doctor will admit to hating herself? I wasn't who I imagined I'd become. I wasn't even close. I imagined that I would cherish caring for patients and embrace the practice of medicine. But in less than a year, something within me changed, and that image seemed unattainable. That was my first passage. And next, I'm going to read from a later part of the book. It's also, as background, a Saturday on Call. The 11th floor of this hospital is a state prison, and Dr. Eva Scott is one of 2 doctors on call. She covers the very active acute internal medicine service patients, and the moonlighter, who's a more senior doctor on call with her, is supposed to cover the rest of the patients in the hospital. And we start again with the pager. Beep, beep, beep. This is Dr. Scott returning a page, I said, after calling the number I recognized as the prison ward. Yes, it's about Freddie Martinez, said Ben, the ward's veteran head nurse. He keeps refusing his potassium since yesterday, and I'm getting nervous about the number of doses he's missed. Okay, I said, taking a breath and wondering what this had to do with me. He's not on my service. Shouldn't you be calling the moonlighter? The moonlighter isn't answering any of my pages today. That leaves you. I blew out a mumbled expletive. I had a long list of tasks to complete before my day could be over. I didn't need extra work. What am I supposed to do about it? I asked. Can't you just document in this chart that he's refusing? You need to come and talk to him so it can be properly documented. It needs to be done by a doctor. But I don't speak Spanish that well, I confessed. Neither do I, he said before ending the conversation. I passed through the 11 East security gates with my cheeks stuffed with the sandwich I didn't have time to finish, chewing while I walked. I waited for the Department of Corrections officers to decide who would be escorting me, and I guess the slim one with glasses pulled the shortest straw because he's the one who ended up walking me down the hall to the room on the left. Freddie Martinez had non-Hodgkin's lymphoma, previously treated with chemotherapy that severely weakened his immune system and led to a rare fungal infection in his brain called cryptococcal meningitis. The infection caused excessive spinal fluid to build up around his brain. He needed a daily diuretic pill to help reduce the pressure, but that pill also caused him to lose excessive amounts of potassium in his urine. That was why he needed to take the daily supplement. I knew Freddie well because our team often got involved for his advanced care. I felt nervous stepping into his room, not because I was afraid of Freddie. No, Freddie was a friendly regular to me. I was afraid of having to explain all I needed to say in Spanish. He was a 39-year-old man of medium build with thinning black hair. He stood up when I arrived to the foot of his cot. He wore a striped hospital gown over a bathrobe. He wore a striped hospital gown like a bathrobe over a white t-shirt and white scrub pants. I took a deep breath and started with my best slow Spanglish. Freddie, ¿por qué you no take potassium medicina? ¿Por qué? I used my hands, hoping he would understand some gestured movements, but he shook his head and tilted it to one side with a smile. Doctora, habla en español, he said, encouraging me to try. I exhaled the dread and then took a deep breath of courage. Okay, I stuttered. Es muy importante que usted come tu potassium. Si no come, usted enferma. Su muscles, su corazón enferma. He laughed. It was a kind laugh, but still he laughed at me. I felt the humiliation, but kept hope that my shameful attempt worked. It did. Freddie shook his head again, looked down at his feet, and then, to my horror, he answered back in Spanish. Not despacio for a gringa Spanish. This was real Puerto Rican Spanish, and it sounded like, no soporto something something, tira hizo al something something, lo puse something something, yo prefiero something something. I had no idea what he was saying. Anybody up here speaks Spanish? I asked the DOC officer at the door. The corners of his mouth pulled down. I don't think so, Doc. Let me check. He stuck his head out of the doorway and yelled, anybody speak Spanish? We waited for an answer, but nothing came. I guess not, he said. I looked back at Freddie, who shifted from one foot to the other, waiting for me to sort something out. I pinched the bridge of my nose to think. We didn't have interpreter services on the weekends, but we were instructed to utilize the services at an affiliated hospital over the phone. Un momento, por favor, I said, holding up a finger. He sat down on his cot and I left the room for the nurse's station. After 3 pages and over an hour of waiting without anyone calling me back, I gave up. I pinched my entire forehead searching for another idea. I called Ian. Ian is Eva's boyfriend. Hi, can you help me translate for this patient? I was still pissed at him, but I didn't know what else to do. These were the days before Google Translate, and Ian was fluent from his Peace Corps days in El Salvador. Sure, what do you want me to say? Well, first I need to understand what he's saying. He's refusing to take his potassium, and I want to know why. I paused for a moment, not sure how much to disclose. He's one of the prisoners. Is that okay? Yeah, sure. Ian sounded excited, too excited. Put him on the phone. Okay, thanks. I stood up to gather my things. I'll call you back after I speak to the captain. At the front security gate, I made my request to a stout man whose brow cast a shadow over the upper part of his face. Absolutely not, he said flatly. But interpreter services isn't calling me back, and I need, no, he interrupted, raising his dark eyebrows away from his eyes. Under no circumstances can an inmate use your phone or any other phone without written authorization. Not even for a Spanish interpreter at University Hospital? Nope, not without written authorization, which takes a few days. So what am I supposed to do? His bulky shoulders lifted up to say, not my problem. I had no words to respond. How was I supposed to help the patient if no one was helping me? Ian was disappointed, but he helped me convert my words into Spanish. Freddie listened as I read the translation about the risks of his decision. He smiled and shook his head to maintain refusal. I looked around the bright room, feeling lost without another idea. All of a sudden, I remembered my senior resident's lesson. You gotta learn to make things easier for yourself. Puede come bananas? I asked, thinking of a way to avoid his heart from going into arrhythmia in the middle of the night. Those types of things always seem to happen in the middle of the night, and I really wanted to give myself a chance to sleep. See, he said. All that nonsense took almost 2 hours to figure out. If I'd offered bananas from the beginning, instead of trying to understand him, I could have saved myself a lot of time and hassle. I wanted to be the doctor who listened to her patients, but this was another lesson learned. I can't always be the person I want to be. And when in doubt, think of something simple like bananas. Thank you.
Okay, so thank you very much, Zenaria. That was lovely and powerful. And we'll hear next from Elizabeth Wood.
Thank you. And I want to say thank you to Richard and Nicole for the roles that they're playing tonight, and to Zenaria for sharing your incredibly powerful work and for putting this entire event together. I'm so grateful that I had a chance to meet you and to work with you like this. So Bound is a memoir about caregiving in a complicated family. It deals with aging parents and sexuality. It deals with codependence between a mother and a daughter and conflict between siblings, but it also deals with the problems of our healthcare systems. And the pieces I'm going to share tonight are about that last part, specifically about the ways that the bureaucratization of healthcare dehumanize medical practice from the patient's perspective. And I am really so grateful and so moved to hear Zenaria's account about how the same kinds of bureaucratic problems and demands dehumanize medicine from the doctor's perspective, because I think I would have understood my mother's experience differently if I had had access to Zenaria's work initially. So to set the scene here, my mother's been diagnosed with a terminal cancer. She's in between her second and third rounds of chemotherapy, and she's been in the hospital for a bit over a month at this point. And in addition to the cancer, she now has shingles, which is causing delirium, and C. diff, which, if you know anything about C. diff, you know there's a lot of shit involved, excuse my language. There's a lot of poop in my story. The first scene I'm going to read focuses on a kind of casual inhumanity that comes when doctors put their own schedules ahead of patient needs. And Zenaria's reading a minute ago shows exactly why they might need to do that or feel tempted to do that. So in this story, we've just survived a night and a morning that's been consumed by attempts to contain this diarrhea that my mother was having, with a sequence of rectal tubes, and none of them really worked very well. To make it worse, imagine the nightmare that happens when a delirious and frail woman gets out of bed when she's been left alone for just a few minutes and tries to make it to the bathroom, which is 6 feet away, while she's attached to her bed by a rectal tube, which is only 3 feet long. Not a good scene. So when I get back to her room, she's furious because not only has her nurse inserted another rectal tube, which is a painful process, but also the nurse has installed a bed alarm to keep her safe. And now my mother feels like she's being punished for something that she swears she didn't even do, even though the evidence that she did is still being cleaned up. So a few minutes beyond that moment, she's finally fallen back asleep, and that's when this scene occurs. When Shania comes in to check mom's blood sugar, I glare. If you wake her, I'll scream, I think. But Shania is very gentle and takes the reading without mom ever noticing. A half hour later, while mom is still sleeping, the infectious disease team comes in to see her. I explain that she's had a hard morning and needs to sleep. The team consists of an attending physician, a resident, and a medical student, each of whom murmurs something sympathetically. Then the attending physician, Dr. Frick, gently pulls aside mom's gown to show the resident, Dr. Imad, and the medical student, whose name I neglect to write down, mom's shingles rash. They note the places where it's healing. They even lift one of her breasts to examine the extent of the remaining blisters. While I fume silently, I don't object. I'm appalled that they'd touch the breasts of a sleeping woman, but I don't want them to wake her, and I do want them to get the information that they need. Later, I will learn that I can insist a doctor return at a better time, but right now I'm just a worried daughter, inexperienced in medical advocacy, who sometimes identifies more with the doctors and nurses than with the frail woman in the bed before me. I'm torn sometimes between advocating for what my mother wants and helping healthcare workers do what I think she needs. Sometimes I even feel like I'm part of her medical team rather than her primary supporter. At 2 a.m, when I decided with Jamie, the nurse at that point, about the third rectal tube, I'd made exactly that mistake. This time, though, the balance tips towards mom's comfort as soon as Dr. Frick moves to roll her over so he can show the others the rash on her back. Don't. The word comes out of my mouth before I'd given it any thought. He looks startled. I apologize and give him a short version of the evening's adventures and explain that I just can't allow her to be awakened. Then Dr. Imad, the resident, tells me that the varicella zoster virus that caused the shingles showed up in mom's spinal fluid and might be the cause of the delirium. He explains that they've started her on an IV antiviral medicine, which should help clear things up. I've reflexively opened my notebook like I always do when a doctor enters the room, but I write nothing down. I've heard all this before and suspect it's really more for the medical student's benefit than for mine. Or maybe he's being evaluated by Dr. Frick. I don't know, and right now I don't even care. They leave the room and I fume some more. I'm angry with myself because I let them touch her while she was sleeping. I'm angry with them for privileging their own schedule over her dignity and her privacy. I'm angry with the nurse for inserting the third rectal tube despite our agreement that there would be no more. And I'm angry with my mother for getting out of bed. I'm angry that this woman who has tied men up and flogged them and used medical devices on their bodies is now too weak to control her own. So that's the first scene. The second scene deals more with the bureaucratic rules and procedures that interfere even when a healthcare worker is really trying to be compassionate and helpful. So in this scene, we've just arrived at an acute rehab facility. This is just a few days after the scene I just read. We've just arrived at an acute rehab facility where my mom is hoping she's going to get some serious physical therapy before heading back to the hospital for her third round of chemo. I need to go to the bathroom, mom says. I try not to be irritated. We just got here. Going to the bathroom is not the simple task it once was. Mom is weak, unable to walk on her own, and unsteady when she walks with assistance. At the hospital, the whiteboard in her room always noted either X2 or X1 to indicate whether she needed one person or two to help her move around. Nothing goes without a code at the hospital. Right now, she's an X1 with the understanding that she uses a walker for additional support. I can't always hold her up on my own if her knees start to go out, and right now there's no walker in sight. Still, when a girl's gotta go, a girl's gotta go. We've been amply introduced to the prodigious diarrhea that accompanies her C. diff, and the infection hasn't seemed to completely run its course. We both know that if she says I have to go, there's no time to mess around. Okay. Let me see if there's a bedpan. I direct this plea to her bowels as I begin rummaging around the room. No, she says, I don't want a bedpan. I want to go to the bathroom. Who can blame her? Bedpans are uncomfortable, undignified, and messy, and that bathroom is far nicer than either one of us has at home. I'd prefer her to be able to use the bathroom myself, but this just isn't the moment for a fall. Okay, let me ring for some help. Why can't you help me? Just help me get up, I can do it. She starts wiggling toward the edge of the bed. I'm skeptical. I move back around to the side of the bed. I feel like I need to contain her there. She's very wobbly on her feet right now, and she's recently been experiencing unpredicted blood pressure drops when she stands, makes her legs as sturdy as boiled noodles. We can't really do this safely. I can help you when you have a walker again, but we don't have one right now. Let me ring for the nurse. Mom is getting frustrated. I don't want to ring for the nurse. If she wasn't busy, she'd be here by now. I had a walker. Where's my walker? I know she's asking a sensible question. She had a walker just an hour ago at the hospital. And I'm sure it doesn't occur to her that walkers are attached to the facility, not to the patient. But I can feel my own impatience rising. That was at the hospital, I remind her. You don't have one here yet. I'll ring for the nurse, but in the meantime, let me just grab the bedpan. I don't want a bedpan. I'm about to make a sympathetic agreement while encouraging her to use it anyway, but she gets one leg over the edge of the bed and instead I get angry. Mom, I touch her leg and I'm about to put it back in the bed as if it's mine to move when the nurse comes in. She introduces herself and the glare Mom was just aiming at me diffuses into the smile she unfailingly finds anytime a member of the medical establishment enters her room. No matter what complaint she's telling me needs immediate attention, if a doctor or nurse enters her room and asks how she is, she smiles and says she's fine. The nurse begins to ask how Mom's doing, and I quickly interrupt. I'm sorry, my mother needs to go to the bathroom. Can you bring a walker or help us get her to the toilet? The nurse looks surprised. Has she been evaluated by physical therapy yet? Seriously, I think. We've just arrived and you're here to do intake. No, but she had a walker at the hospital and they wanted her to walk when she could. Has my mother disappeared? Why are we talking as if she isn't right here in front of us? I see, says the nurse. She seems to have been asking herself the same question I was asking a second ago because she turns to my mother. Mrs. Wood, I'm sorry. I can't bring you a walker until your physical therapist has evaluated you. He'll decide what equipment you need. Unfortunately, they're gone for the day, so let me get you a bedpan. Why do transfers always happen just after the people who can help have gone home? Mom looks at me, quiet but tense, as if waiting for me to advocate on her behalf. I make a weak attempt. She'd prefer to use the toilet. Maybe together we could walk her over there? Suddenly, Mom speaks up. I have to go now. The urgency in her voice is unmistakable. The nurse goes into the bathroom to retrieve the bedpan. It only takes a few steps and a couple of seconds, but by the time she gets back, it's too late. The nurse calls for a nursing assistant, and together they clean my mother while I find a clean pair of sweatpants. Then they help her to a chair where my mother sits, staring at her hands in her lap, refusing to look at me or at them. I watch them change the bed instead of trying to engage Mom in conversation. The two women are cheerful in demeanor and seem determined not to add any further humiliation to what my mother must already feel. I wonder if the nurse is asking herself if she shouldn't just have ignored the walker regulations. Next transfer, I vow, I'm taking the walker with us, petty theft and policies be damned. That bedpan scene, repeated in various forms in many settings, is a classic example of the conflict between individual needs and bureaucratic rules. My mother needed to use the bathroom. The tools required to help her do that were controlled by a process outside of our hands and really outside of the hands of the nurse who was assisting us. The nurse was focused on fulfilling the expectations of her role in that moment, completing the intake process and following patient safety procedures, rather than on meeting my mother's self-determined needs. The notion that a patient should be able to use the bathroom with dignity whenever possible is one that every nurse I've met during my mother's illness would find perfectly reasonable. But the number of times this has been made impossible because of a rule or a role was astonishing. Hospitals and rehabs, like boarding schools or prisons, are total institutions. Total institutions are total because while we reside within them, their rules and procedures control every aspect of our lives. Every time mom moves from one total institution to another, new rules come into play. Each hospital or rehab staff members must do their own evaluations. Every move is like starting from square one. Even returning to a place we've been many times, like the hospital, where mom is often cared for by nurses who remember her and with whom she's gotten quite friendly, requires an intake process that makes us feel like we're newcomers. Worse, every transfer represents a potential setback. Mom's hospitalizations tend to be long. Her most recent lasted over a month, and in that time, she'd made significant progress with a physical therapist. Too weak to stand at the height of her C. diff infection, by the end, she was sometimes able to take a short walk around one part of the unit with the aid of a walker and another person by her side. She'd gone from being bedridden to being an X2 to being an X1 if she had that walker. Transfers disrupt this process. A new physical therapist has to start from a new square one. And given the timings of transfers, it's not uncommon for a weekend to go by without mom doing any significant physical therapy work. When this happens, she loses the gains she's made, and sometimes more. 2 steps forward, 3 steps back. To call it frustrating is an understatement on par with Houston, we have a problem. Thank you.
So thank you, Elizabeth and Zenaria, for that reading. I think we should give them a round of applause. I don't know if, Nicole, we can unmute everybody just so that people can clap.
Yay. Awesome. That was amazing.
Enjoyed both of them a lot.
That is one of the difficulties sometimes of doing literary events on Zoom is getting, the visual feedback of the raised hands or the hand claps is one thing, but it's always nice. Am I on? Okay. It's nice to, as I was muted, I was saying how nice it is to hear the sound of clapping, which, is one of the nicer things at the end of when you give a reading. So that was, as you heard, both Elizabeth and Zenaria, the very powerful experiences and very powerfully written experiences. And so what I thought I would do is when, they sent me the material that they were going to read, and I made some notes and to help start a discussion. And I thought what I would do just to start the discussion is read for you a short bit from the note that from the notes that I took when I was reading through their work, and then just toss it out for discussion. Please don't feel constrained in any questions or comments that you might make to what I'm going to say now. If you have your own, please ask, please say. And we'll just kind of see. I have some other questions prepared to kind of help motivate and facilitate discussion if necessary. But really, once I'm done, I hope that you all will kind of lead the conversation so that we can have the conversation that you all want to have, rather than anything that we three have kind of discussed ahead of time. But this is what I wrote, excuse me, after reading both of the excerpts that we just heard. Because the problem of staying healthy is about our bodies, the stuff of our material existence, it inevitably confronts us with the question of what we can and cannot control, of what we must surrender to the control of others in pursuit of our health, and of what we have the ability and what we should have the right to choose to surrender or not. One way of looking at the healthcare industry is as a bureaucratic response to that question. It dictates how we manage the process of control and surrender. We usually think of these questions in terms of patience, we usually think of these questions in terms of patience. Elizabeth's memoir makes these questions palpable as she tells the story of her mother's illness. Zenaria's work, though, illustrates how these same questions can be asked in the context of how the medical profession trains doctors. During the time that I am blanking on your character's name. Dr. Scott, right? During the time that Dr. Scott is on call, she does not really have control of her own body, not when she sleeps, not when she eats. She is forced to pump herself up on caffeine and Sudafed. And she has to run from this place to that place to the other place, kind of at the beck and call of whoever needs her. Moreover, she did not have the benefit of an advocate like Elizabeth, someone who was not going through the same process, who could see what was happening, if not precisely objectively, then certainly with more clarity than someone in the middle of it, and someone who could speak up for her as Elizabeth was able to do, however imperfectly, for her mother. So that parallel was something that struck me, because we normally think of doctors and patients as being sort of on complete opposite sides of this process, and yet as you listen to these two pieces of work, they are also people in the midst of a system that has control of their bodies, and that therefore you can start to talk about how that system thinks about their bodies, treats their bodies, understands their bodies. And I should say that when I say body, I don't mean simply physical, your physical substance, but emotional, psychological, all of the emotional and those kinds of things, because that also happens to us in our bodies. They're not really separate from our bodies. So I thought I would throw that observation about the two works out there, and then throw it open to you all to see what you think, hear what you have to say. You can write your questions in the chat. You can raise your hand and ask them out loud. Nicole will read questions from the chat. If you ask them out loud, then Elizabeth and Zenaria can respond, directly to you. So, Nicole, do we have any questions in the chat?
So far, Michael Grossman has just pointed out that there's a sociologist, Charles Bosque was a sociologist who wrote about how surgeons forgive errors and sadly just move on. And then he follows up, what do you think can be done to fix this? And then,
sorry.
Dr. X says, why is the system this way? Those questions can probably go together.
Go ahead, Elizabeth.
Well, I was just first going to ask you if you had a sense of why the system works this way from the doctor's perspective. But as I was about to ask that, it occurs to me that there's one piece of the healthcare system that's really not part of the story so far. I know it comes up in my book, and I'm sure it comes up in yours, and that's the insurance company end of the story. And it seems like a lot of rules and procedures are actually responses to demands by insurance companies. And so like the question of who else is in the room here controlling the bodies, often it seemed to me as I was reading your work that the doctor isn't in control in the same way the patient usually thinks of the doctor as being in control. When I was with my mother in the hospital, I very commonly assumed the doctors ran the show. I mean, I knew her insurance company, Medicare and other insurance rules were governing things like what kind of rehab we could go to. But in terms of the everyday movement through the system, I think I thought doctors had a lot more control than they did until I read your work.
Yes, well, I mean, there's maybe the question of why is it this way? I did some research recently on the history of medical training and how we got to where we are. And what I found was that the first medical residency, at least the first surgical medical residency, and the model on which our residency programs are based is from Johns Hopkins model. There was a surgeon by the name of William Halstead who started the first surgical residency. And it was known to be very demanding. It was a pyramid structure. So only one person ended up at the top as chief resident. So you have a lot of competition from the bottom amongst residents going up to the one who gets the chief residency. These residents were on call every day, all day. They were encouraged not to get married because God forbid your wife call you to come home that guests are coming over and you have to leave the operating room. And so this was this was a culture. Dr. Halstead also suffered from addiction to IV cocaine that he became addicted to after experimenting on himself. So there's that background in terms of what informed this type of culture. Someone who had this drug addiction, but also very high demands, and within a very well-known and great institution, trying to be the leader for medical education and medicine in general. And so a lot of medical schools and residency programs became like that because his trainees went other places and established that culture around the country. And things are a little bit different now, but that's kind of where things started. And a lot of times things occur because that's the way our seniors were trained.
Mm-hmm.
And there's a hierarchy in medicine. So maybe that answers some of your question of why things are. There are a lot of regulations that have been put in to help reduce the work hours, for example, and some other things in medicine. But those are not always being observed. And that's just the truth of it. Residents write down that they work 80 hours, but they really work more.
Mm-hmm.
So there's still this background of just needing to work to a certain level, and it's something that's perpetuated.
It struck me as you were talking that so much of the culture that we have around medicine right now is partly unintended consequences of attempts to do good things, like train doctors to the highest standard of expertise or rationalize patient care to reduce errors and things like that. But there are so frequently these unintended consequences that end up harming not only patients, but as you demonstrate so powerfully, also end up harming doctors whose responsibility is to care for those patients.
Yes, absolutely.
In the chat, Rob Vickers says, don't forget the ever-present fear of litigation, which drives many of the procedural headaches and roadblocks to what may seem like common sense, not letting a patient use a walker until evaluated by PT.
Yeah, that really seems like it goes along with that question of who else is in the room, right? It's not the doctor, the nurse, and the patient. The insurance company is invisibly in the room. And as that question points out, as the observation points out, there are lawyers in the room too, essentially. And what can be framed as something that's necessary for patient safety is also at the same time something necessary to protect the hospital from litigation. And so that increasing rationalization of the process seems like it's got this benevolent intent of trying to protect all kinds of people from harm. And in doing so, it eliminates the humanity in the process of caregiving. There's got to be a way to change that.
Yeah, that it dictates a lot of what we do, from surgery to a decision of whether a patient can have even a walker.
One of the things that I wrote about in a different part of the book was consent practices. And those too are intended to make sure patients know what they're about to agree to and to protect the hospital from litigation and to keep doctors from doing procedures without patients' knowledge and all of that. But the consent process also has been rationalized to the point of being essentially meaningless. Because you're very rarely going to ever say no. My mother was in the hospital for chemotherapy. She had to sign a consent every time she was going to get the chemotherapy. Of course she was going to sign the consent. I know there are situations where it works differently, but it's one of those situations where I thought, healthcare workers could actually learn quite a lot from sex educators about what does meaningful consent look like. If you just put a form in front of somebody and say, we need you to sign this in order to do the treatment, and then in a robot kind of way, read through the provisions because you've heard them 1,000 times and you don't really have that much time to do this anyway. And the patient is just going to sign it because we know that's going to happen. There's not much meaningful consent gained there. There were a number of times when my mother needed to be catheterized, and instead of a nurse coming, and in fact, even in the C. diff treatment, where she needed these rectal tubes, right? And the lifting of her breast, like there were so many points where intimate parts of her body really needed to be dealt with in this pretty cold, callous way. And I can't remember a single instance where somebody tried to gain meaningful consent to touch her body for one of those procedures. But I can understand why. And that too seems like, you know, I mean, that shouldn't happen.
I think one of the also restrictions that are put on us because of insurance is the amount of time that we can spend with patients.
Mm-hmm.
And that's in an inpatient setting and also an outpatient setting. We have a certain number of minutes that we have for a very complicated person. And you can't, you know, always give that person everything they deserve in those 5 minutes because you have several other people that you need to see also before your day is over. And that is also, that constriction is due to payments and how much how much insurance companies pay for a certain time, certain visit, even a hospital stay. We're encouraged to get people out as soon as possible. I don't work in inpatient medicine. Maybe some of my colleagues who are on the phone here do, but there's that pressure of just to see as many people in as little time possible.
So Amy Parsons asked, why did doctors stay? And then let me add Luvan's question to that. And that's, as medical schools become majority female students, do you see any changes as yet in patient care and physician care? Are women becoming chief resident? Are women attaining other leadership roles? Or is it simply the culture you describe and women's leadership simply sustains the traditional culture in the profession?
Well, the first question, why do doctors stay? I think that's obviously pretty individual, but for me personally, I stayed because I had $150,000 of debt. And I needed, in my mind, I rationalized staying in my internship, which mirrors Dr. Scott's experience, because I needed to have a doctor's salary to pay that. I couldn't just go teach yoga or something. And so there's also fear, and there's a lot of time, let alone money, that you've invested. And there's a sort of identity. For me, it was, well, if I'm not a doctor, what else am I? I've been an aspiring physician for most of my life. And it was scary to think about doing anything else, even though I wanted to jump out and do something else. Unfortunately, some people feel that they need to take the ultimate sacrifice, and some people do take their own lives. And we do have a lot of issue with physician suicide in our culture. So those are the reasons why I stayed. I think there's also a hope that things will get better. And for the women in medicine, yes, there's definitely more women in medical school and residencies. Yes, women are chief residents. They are, you know, and there, I think there's still a bit of a challenge in breaking into some higher positions in academic medicine in particular. Women are also oftentimes mothers and have to leave for perhaps maternity leave. I know a friend who because of that, lost her chance of being partner in her practice. I know a friend who didn't get a promotion in part because of the time she had to take off for her child. So there's still these challenges that just come with life. And I think recognizing that women deserve a place in these positions, but also need to be able to spend time to raise their family, because this is how it works. I hope to see more of that change, but there's still a lot of work that needs to be done for that.
So I'm sorry, what you're saying, Zenari, it made me think of just it illustrates just how much medicine is part of the larger culture, right? I mean, the problem, what are the obstacles that women may be facing in medicine, but also the way in which you described the medical training, its origins with Johns Hopkins and all of that. I was just struck as you were speaking how similar that is to the kind of hyper male business culture. That you go to work for a company and you give everything that, you give everything to the company, and you don't take time off to be with your family. And you don't, and if you do, as a man, if you do that, you are somehow not good enough, or, you're a drag on the company's bottom line. And I just wanted to point out that, that parallel, both in terms of kind of what feels like, a gendered set of expectations. Anyway, I just noticed, that's just something that I noticed that I thought I would throw out there.
So I teach sociology of gender at Nassau Community College. And one of the things we talk about is the way that workplaces in general in this country are built around the expectation that the ideal worker is a man with a wife who takes care of the kids and does all the stuff that has to be done at home. And it struck me, especially learning more about medical training through Zenaria's work, that medicine is like that on, that times 10 in terms of its demands on workers. But I wanted to say, so the passage I read about the infectious disease team was unusual in my experience with my mom, only in particularly in the sense that that team was made up entirely of men. And so my mother's care was mostly delivered by oncologists, and it was at a university, a teaching hospital, university hospital. And all of the hospital oncologists that took care of her were women, young women particularly, and her attending oncologist was a woman. And I did see gendered differences in the way that they interacted with her. What they couldn't do was change the rules of the system. But I did see differences. I don't believe a single one of those hospital oncologists would have treated my mother while she was sleeping the way that infectious disease team did. And I do think that there were some gendered dynamics that went on there. And so in that sense, perhaps I was able to witness a bit of cultural change in terms of interaction with patients. But so much of the interaction is actually governed by rules and procedures and things, and not just the particular orientation of the physician. I see in the comments, I see somebody has said, oh, somebody with my name, in fact, that's very unnerving almost, that it's the same in most large law firms.
I thought that was you. That's funny.
No, that's not me.
So there's lots of questions. There's two that maybe I'll kind of put together. So Fela Cortez is saying that this discussion is so timely while the nation is discussing healthcare. And then the question kind of pivots to be more of like a book question. How does the Dr. Scott character find her way out of this labyrinth? How do you find your way back to humanity? Could she find the earlier version of herself? And they hope the story is resolved in the end. And then, where's the other question? Oh, and so Zenaria, that's sort of a book question, what happens in the book, but then Sarah Clark is wanting to know, what's it been like speaking out about your experience as a medical student and doctor while you're still practicing medicine? Has it been empowering speaking up and sharing your story? Any fears? What has inspired you to continue writing?
I think I'll answer the last question first by Sarah. It has been pretty terrifying. But you know, every time I see a report of a medical student or resident that stepped off a building, it empowers me. And in fact, I learned last year that a friend of mine killed himself. I knew him from fellowship, Byron Dean. And, you know, there's a lot of things that go on that make someone make that decision. But I know that the practice of medicine and the culture of medicine led to Byron's and even perhaps some of the others. So I, especially after I learned about Byron, I actually didn't want to put my name on this book. I was afraid to expose myself. I was afraid of being shamed, of being wrong, and I wanted to hide. And so I made a character who was just really very general, and that just wasn't working. So with some work and just with myself and trying to build up the courage to be a voice for to be a voice on the side that is not often heard. So that was my motivation, and that still continues to be a motivation to move forward. There are some doctors who don't like what I'm doing. I get kind of a look when I talk about the subject of my book, but most are very encouraging. And I went to a writers' convention one time, and they said that one author said, if you don't see a subject in the bookshelf, then that's potentially a subject that needs to be filled by you. If that's your experience, if you don't see it there, then write about it, because you're probably not the only one going through that. And the other reason is to show a side of the story so that people don't feel like they're suffering in silence. So a part of the opening is, you know, starting to stay tough, showing that you can keep it together, in competition with your peers, that, you know, even staying up all night, you can still be as tough. And part of that was because Dr. Scott is a woman and all of her other interns are men. She's also a woman of color, and the other interns are white. And so there was this sense that she, you know, had to perform. And so all these elements are not really out there not out there enough. And so I feel like they should be out in the stratosphere in the world. In terms of what happens to Dr. Scott, I would, you know, be happy to tell you when the book is done. You can come to my book launch. You know, it does, you know, she represents me, and I think you can see that I have some humanity. It does take a while. Everyone has their different path. For me, it just took a lot of time. I think I had to bury my humanity, so to speak, just to be able to get through the day, just to get through the year. It was a little bit too hard to be the person I wanted to be as an intern, because the system was just too hard on me. And for whatever reason, I took it really hard. So there is a happy ending, but battle scars are still there, even though she's healed.
So if I can maybe introduce another kind of topic into the discussion, there is a kind of a it's a newly emerging field in higher education and graduate school called medical humanities. right? And I mean, if you think about it, it's kind of interesting that that needs to become a field where the term medical and humanities actually kind of get forced together in a juxtaposition that should have seemed kind of obvious all along, right? And I had some small personal experience with it. As part of a program that the New Jersey Council on the Arts was running, I went to two or three different hospitals and gave poetry writing workshops there. And what was unique about those workshops was they were not simply for the doctors, the medical staff. Anybody in the hospital was welcome to come and be part of the workshop. And the idea was for them to, to write about in some way their experience working in the hospital. So you had everybody from the cafeteria workers and at least one of the chief residents actually did come. The chief resident actually did come to the workshop. And so I offer that partially as a response to the questions, that there is an initiative out there to kind of change things, at least in the educational system. I don't know that it's in medical schools yet. I just don't know, but there is this initiative out there. But I wanted to offer it up for two reasons. First, because I thought the program that I was part of, it was interesting that it included the entire hospital staff. And it was not so that there was not this kind of distinction between the janitors and the cafeteria workers, that sort of labor, and the medical labor. But also just to ask each of you if you have any experience with the field, if you know it, and if you think it offers hope, or what your experience might be with it.
I've been dying to get my book into and myself into some medical humanities circles, and I don't have the contacts right now, but I know Columbia University has a medical humanities program, and so I'm looking for connections there and trying to reach out to some folks there, because one of the things you said, Richard, that seems so important to me is that care is provided by all parts of the hospital, right? Not just the doctors, not just the nurses. And one of the problems that I think I saw as a patient or patient advocate or family member was the siloing of responsibilities. And so anything that gets people talking across job categories would seem really valuable. I would love to see a program where doctors and patients share that kind of experience, where a writing workshop might go on. I know there's a lot of turnover, both in terms of like shift work for medical staff and also, or for hospital staff in general, and also patients are always churning through the system. But the idea that there could be workshops like that patients and doctors would both participate in, and along with people like transport workers and cafeteria workers and so on. That just sounds so powerful to me, because as Zenaria and I have been talking, like I said, toward the beginning of the discussion, one of the things that really moved me was realizing that she and I experienced very similar loss of control, albeit in different ways. We lost control of ourselves in different ways, or of bodies and mind in different ways. But that intrinsic feeling that you don't control anything for yourself, to be able to share that and understand the vulnerability that's being felt by the person that you're set up as opposite to in some way, I think that would go a long way toward building trust. We have so many problems in our medical system right now, and lack of trust is one of them. There's a whole other question, I think, about how to really fix this problem, and I think it's been alluded to a number of times that capitalism is part of the problem here in insurance companies and the way we fund healthcare. But to focus on the human interactions and to find places to make more of those interactions, through a writing workshop sounds like a fantastic way to do it. I would love to see more of that.
Just in the chat, Luvan also mentioned the Columbia University's narrative medicine program, and Michael Grossman mentions that some hospitals have family faculty, patient advocates who sit on hospital decision-making committees.
I'll offer, there's a poet named Rafael Campo, who is a physician, and I'll put his name in the chat. And he has written, and of course now I'm blanking on the name of the book, but he's written a book about his experience using poetry in the process of caring for his patients, where part of what he does is as part of the care, when the patients come, he will give them poems to read, and then discussing the poems becomes part of the care that he gives. And I wish now that I'm saying it, I can't remember the title of the book, and I can't remember any of the specific stories from the book, but I'll put his name in the chat. And it's an interest, given what we're talking about and given what Elizabeth just said. I think it's a really interesting, if you're interested in that, it's a really interesting thing to kind of check out. Now you look like you were going to say something.
Yeah, I was thinking about the question about fixing, how do we fix this? I think that part of the reason why we're having this discussion, part of the reason why I am continuing to write, is to identify the problem. There is a lot more discussion on this. I mean, from the physician and healthcare worker side, there's a film called Do No Harm. It's a documentary that goes into great detail about a lot of these different aspects of why residency training is the way it is, and how it burns out physicians. I think that for me personally, I think having gone through my process, I treat my residents very differently than how I was treated. I don't pimp them. I don't think I introduced that word in my reading, but I don't ask them a bunch of unanswerable questions or just a lot of questions in rapid fire sequence. If they don't get an answer, I give them a pretty long explanation and almost like a lecture. And I think they regret that they didn't know the answer in the first place. And today we had a very busy clinic so that I can make it here on time, but I insisted that my first year resident stop and take lunch. And he kind of paused and was shocked that I told him to just stop, close your door and get something to eat. And he said, okay, because I'm his attending and I'm giving him an order of what to do. And so I don't know, I hope that, and everybody got seen. We took care of all of our patients. Maybe they had to wait a little bit longer, but we gave them our time. And so perhaps with people, change happens with individuals. And so maybe another chain of events can happen in this direction to help turn things around. The AMA is also doing some initiatives on physician burnout associated with physician suicide, which is a big problem. So it's becoming more part of the conversation, whereas before it was definitely swept under the rug. I didn't learn about Byron's suicide until 6 months later. Our fellowship program didn't put anything in the newsletter that I get every month, nothing about him. And so, these things I would still like to change, and I just like for us to be more open about things. But again, that starts with individuals making that change for ourselves.
So I thought I would ask a writerly question, since you're each writing books that have, in some way at least, literary ambitions. I mean, they're not self-help books. They're not, right? Elizabeth's book is a memoir that makes a really powerful emotional appeal to the readers, and Arya is writing a novel which obviously has literary ambitions. But the original way I kind of had this question formulated, had to do with, well, how do you put this, how do you find language for this kind of experience? But I was struck by this in particular listening to Zenaria's reading, and I want to ask the question a little bit differently. Elizabeth's reading also. And there's a way in which each of you is motivated by anger, right? And
Mhm.
by you might even call it a righteous anger, right? I mean, it's a healthy kind of anger, right? It's not simply complaining is kind of what I mean. And I thought, the kind of, to ask the writerly question this way, which is how do you find the process of not allowing that anger to overpower the writing? Because neither of your work is the work is not consumed by anger, right? The anger emerges from the work as something that is necessary. And so I just thought I'd put that out there as a question. And maybe that'll be our last question. We'll see how that goes.
Zenaria, do you want to jump in first, or do you want me to?
You can start, please.
One of the things that happens in my story is that I write a lot about the process of controlling my emotions during the time my mother was sick. So there's a prop that appears frequently in the book, and it's this notebook that I always have with me. And I use the notebook explicitly. I use the notebook to keep records of everything that's going on, what medicines, what procedures, what's the course of her treatment, and all that kind of thing. But it becomes clear to me because of an interaction I have with one of the doctors, actually a really powerfully human moment with a doctor, a social worker, and a chaplain all sitting in a room together with me after a really hard night, that I've actually also been using the notebook as a shield. So one part of the answer to your question, Richard, is that the anger doesn't overpower the story, partly because it was very controlled also in the experience, with a few exceptions, with moments where it just really bubbled to the surface and took over. And so in writing, in trying to write a very emotionally honest story, one of the things I had to account for was that there were a lot of parts of the story that were pretty cold, because that was the emotional reality of the moment. But there was also a wide range of emotion. There was sadness, there was humor, there was anger. There were feelings of not having done a good job. There was, self-criticism. There was all kinds of stuff going on in the story. And so there are scenes that are motivated by anger, but the whole story is actually motivated by a much more complicated mix of emotions. And in trying to account for that honestly, I think that helped keep any one emotion, including anger, from taking over the story.
Thank you. That's interesting.
That's an interesting observation. Your Queens Boulevard here. Richard, about anger, and anger does come up in my novel In Progress a lot, to the point, and in the story. So there's so much anger about what's happening to her and her not having control over so many things going on in her life, that it actually burns an ulcer into her stomach. So it's an internalized anger. So you have these assaults coming from all different ways, not feeling the support from the institution, not having a support system, a personal support system, and the demands of just being an intern, but also coming to terms with that conflict, that internal conflict of an ideal of what she wanted to be and what she is. And that puts in more of a guilt and shame than anger, and maybe an anger from feeling guilty. It's just like this cycle and mix of emotions. And trying to keep it all together, I think, is how she's able to keep it contained. And so I think in the writing, you do see the anger. I've been to a lot of writing workshops about showing and not telling. Earlier versions, you could hear the anger, I think, more. I was told by some beta readers that it had a different tone than it does now. And I think what I decided to do was to really just describe the scene for the reader, describe what's happening, And I think the natural emotion that the reader will get is what you feel that Dr. Scott has. So kind of feeling that with her rather than her telling you about it.
Thank you. So, I mean, I guess part of the reason I asked the question that way is, I mean, each of your books is, you want each of you each want your books to be transformative in some way, right? And I, you know, I do think it's important to acknowledge that when we want the movement towards that kind of change and the demand for that kind of change, you know, anger is an important part of that. You know, to know what you're angry at, to be angry at the right things for the right reasons, and to be able to articulate it precisely with all of the complexity, Elizabeth, that you talked about, right? I mean, because anger, you know, anger is, you know, as opposed to rage, right? Where if you understand rage to be a kind of single-minded, destructive kind of force, and it's not always that, but if you just for the moment grant me that, you know, that's just such an important part of the work that you want the work that you're doing to do, if that doesn't become too much of a tongue twister. And so thank you both for that. Maybe we have time, if anybody has one last question. So I get, okay, so Luvan said in the chat, Nicole, I see, I'll just read this out if you don't mind. Luvan says to Elizabeth, I love that section where you have a notebook and pretend to write in it during the bedpan incident between yourself, your mother, the medical professionals. And now you've just said prop. Love thinking about your notebook as a prop, as an instrument, also as a cover, as a sabotaging character, as an appendage, and I'll keep going, he says.
It could have been all of those things. It certainly was. I actually allude to it as being very similar. I'm a Buffy the Vampire Slayer fan, and Buffy has this favorite stake that she uses. And to me, the notebook felt as protective as that stake was, I think, for Buffy and slaying my mother's demons. So, so thanks for recognizing that. I'll make a shameless plug for a moment for anybody who's interested in reading the book. My publisher has put our fall books from last fall on sale for 99 cents for the ebook. So you can find the ebook for 99 cents anywhere that you buy ebooks these days. So, so check it out if you, oh, and Zenaria's got the paperback there. Mine's a bit beat up. You can see mine too through my virtual background. Yeah, so check it out.
I just put the link to the book on Elizabeth's website.
Yeah, that's.
And I will, I mean, I was going to do your shameless plug for you, but
that's very sweet.
But I will say it really is a marvelous, it's a worthwhile book to read.
Thank you.
It is not a happy book to read, given the subject matter, but it is a really truly worthwhile book to read. It's thought-provoking. It goes more deeply into a lot of the questions that we have been talking about here, and I recommend it. And you know, if we don't support writers, and if you don't support the writers who write about what you care about, very few people will. So I encourage you, all of you, really. It's a book worth getting.
And I can't wait to be among the first to buy your book, Zenaria.
Thank you.
Yeah. This is important work.
Thank you.
So we've reached about the end of our time. Zenaria, thank you first of all for organizing this. This is really really quite a special event. I'm glad that you got in touch with me to ask about the grant, because this, you know, things like this happen by happenstance like that often. And Elizabeth, thank you for being willing to be part of this and for, you know, allowing me to make this match.
Oh, my pleasure. Thank you for making it.
Nicole, thank you. You know, for reading from the chat and from kind of moderating that part of the evening. And thank every single one of you for coming. The comments that you put in the chat were interesting, that you gave your time and attention to this important subject really, really, truly does matter. If I will just pontificate for a small bit and say, you know, I think books like Elizabeth's and Zenaria's and events like this you know, it does its work. They often do their work one reader at a time, one person at a time, kind of slowly as things build momentum. And this, you know, you all for being here have been part of that process. So thank you all so much for coming. I hope you are all safe and healthy. Enjoy the rest of the evening. It's almost the weekend. Enjoy the weekend. Be safe, be healthy, and have a lovely night.